Dr. Wyman. May we go now to Senator Pate, please?
Thank you very much, Madam Chair, and thank you to all of you, and thank you especially Mr. Belanger for the masks that you provided to all of us for this month in recognition of Indigenous peoples with disabilities. I want to ask in particular, well, actually, I'll ask all of you and those of you who are comfortable answering. So I'm sitting in for Senator Boyer today, and she wanted to know whether, in fact, any of you have run into challenges providing services on reserve versus off reserve. I think there's been a bit of answer to that, but if you could elaborate. And also the fact that some Indigenous communities have expressed concerns that the possibility of the expansion of Maid could be countercultural to some Indigenous cultures and traditions, and taking into account Indigenous people's right to self-determination. How can Bill C7 be amended, or how can we ensure that Indigenous people who are eligible for Maid, as well as those who don't have access to programs and services in the community and are only given access to Maid, are assisted in a way that is culturally safe? And I just wanted to add a question from me. You all know the overrepresentation of Indigenous peoples in prisons, and because of the issue of the lack of choice in terms of other treatment options for prisoners, the correctional investigator has called for a moratorium on the ability for prisoners to access medical assistance in dying, because they're not all of the recommendations have been that they should be provided with access to palliative care in the community before the option for Maid is provided. Yet many prisoners are requesting that because they aren't getting access to that kind of compassionate release option. So anybody who wants to comment on that as well would be much appreciated. Thank you.
Dr. LaFontaine.
Sure. Thank you, Senator, for your questions. I'll try and answer each one quickly to give the other witnesses a chance to respond. As far as access to health care, if you don't exist within Indigenous health systems, it's kind of hard to wrap your head around just how little access there actually is. So within urban centers and in the north zone of Alberta, we have 15 to 20% of our population at the hospital that I work at coming from Indigenous communities in northern Alberta and northern BC. Patients who come into the hospital often receive less options when it comes to choices within their care. They often have different interactions where they sometimes get the impression, and this has been told to me by Indigenous patients, that their providers don't want them to have certain types of options, and so they don't pursue it out of fear that they might offend the provider, even though they do know that options are out there. As you move more into the periphery, smaller communities and flying communities in particular, there actually is no service unless a physician chooses to visit. And I'll underline that by saying choose to visit. It is not up to the patient. It is not up to the community. It's not even up to the health system. It's whether or not someone will volunteer to go there. And so the idea that we have some sort of underlying structure in which to overlay any type of access within certain Indigenous communities, there actually is no access at different times during the month. And in some of our flying communities in northern Alberta, they have locum services maybe for a week, which means for 5 days you have access to a provider who can send you off for testing, investigation, do evaluations, or maybe refer you to a specialist, which you actually can't refer yourself to. And so that's the answer to question number one. To number two, introducing Maid to the community and the cultural and social considerations. In the context of not actually having a well-established baseline for health systems, going from having no health systems to having a greater access within urban communities, you can imagine that introducing something that is supposed to be provided to all Canadians would be received in different ways. If the only service that is required by the federal government to be provided within communities across Canada is medical assisted dying, and I'll go as far to say that it probably is the only one that's been approached this way, in a community that has no services, the reception of that is going to be very different than an urban community that has other services available. That communicates very specific things to the community because of the nature of Maid, that the treatment is harm, as I mentioned at the very beginning, and has impacts on the ongoing trust and engagement of communities with the health system. The third comment about treatment options for prisoners, I think is a timely one. We know that Indigenous patients in particular suffer from the type of racism that leads to worsened health outcomes. That's a byproduct of the choices provided to patients, the cultural norms on what's tolerated for patients, and then the choices of providers who actually control resources within the system when it comes to making choices for patients. We know from the tubal sterilization inquest that has been led by Senator Boyer and other champions within the Senate that this is a reality. And this is not a remote reality. This is not a historical reality. This is a lived reality today. I remember in residency, 10, 12 years ago, sitting in ORs providing anesthetics for patients who'd begin crying once the surgeon told them that their tubes were being tied. And I always assumed, as an Indigenous anesthesiologist, that maybe my spinal anesthetic was insufficient or that the patient was just doing a little bit of grieving. It never would have crossed my mind that they had not been been engaged in a conversation where someone actually provided them the space to make a decision about their healthcare.
Thank you very much, Dr. LaFontaine. We'll now go to Senator Boniface.
Thank